So it gets me to talk about things that I really like to think about and talk about. That's patient-reported outcome measures, and things that I hate thinking about, which is differentiating bleeding episodes from chronic arthropathy. Just a show of hands here, who's heard this term or read this term? You can't manage what you don't measure. Just show of hands. Yeah, I'm not surprised a lot of people have heard about it. This is a ubiquitous term in business, and you see it all over the internet. Nobody knows exactly who said it first, but the reason for this, and when you think about this in terms of healthcare, the reason for this is that we all suffer from a wide variety of cognitive biases that sometimes lead us astray when thinking about health problems that we have to deal with. And when we're thinking about, for example, bleeding and hemophilia, the most important bias that we have to worry about is this one entitled confirmation bias. Confirmation bias, the slide says, everything you look for and all that you perceive has a way of proving whatever you already believe. And if you're a person with hemophilia and you have a painful episode, as we discussed earlier, the first thought is, this must be a bleed. And it's for that reason that famous scientists like Galileo have said, count what is countable, measure what is measurable, what is not measurable, make measurable. However, equally famous scientists have said things like, not everything that can be counted counts, and not everything that counts can be counted. Patient-reported outcome measures have come to the fore because, very importantly in healthcare, who gets to decide what's important to the patient at hand? Is it the doctor or the nurse, the therapist or occupational therapist, the family, or is it the patient themselves? And the thought is that patients can often most reliably and usefully report on their own illness in a way that's important to them. And in trying to determine what exactly a patient-reported outcome measure is, I went to the source of all human knowledge, Wikipedia, and this is the definition of Wikipedia. A patient-reported outcome, or a PRO, is a health outcome directly reported by the patient who experienced it. It stands in contrast to an outcome reported by someone else, such as a nurse-reported outcome or a physician-reported outcome. Now, there's nothing new about this. A patient-reported outcome is just, in healthcare, we just call that the history. And it's been around since I imagine, since prehistorical tribal times with the earliest healthcare providers. But the reason we've separated out patient-reported outcome measures is this is an attempt to standardize and objectify the history in a way that's reliable and useful. And let's think about that as it comes to bleeding. However, I do want to make one side note here. And this also comes from Wikipedia, which is patient-reported outcomes should not be confused with patient-centered outcomes. The latter, that is patient-centered outcomes, implies the use of a questionnaire covering issues and concerns that are specific to a patient. Instead, patient-reported outcomes may or may not be of concern to the patient themselves. So patient-centered outcomes or patient-important outcomes are maybe something that's what we're really trying to get at here. Now, of course, when it comes to bleeding, why does it matter? Well, clearly, if pain and swelling is a result of an acute bleed, then treatment with factor is necessary to avoid damage and chronic arthropathy and further bleeding. Whereas, if the pain and swelling comes from already established chronic arthropathy or chronic synovitis, then treating with factor is just a waste of expensive resources and potentially harmful. And so, with that in mind, Meryl Timmer and her colleagues from Holland performed this review article, precisely to look at how well can we differentiate and what do we use to differentiate acute hemophilic bleeding from chronic arthropathy. Now, in this study, what Meryl and their colleagues did was they reviewed 757 papers from which they found 9 that directly addressed the issue at hand. And what you can see, this is the first table from their paper. In the first column is the author and the year of report. In the second column is the source of the information. Did this come from patients themselves or from health professionals? The additional columns are the symptoms most widely reported: swelling, reduced range of motion, pain, warmth, redness, stiffness, and inability to weight bear, to load the joint. So these are all patient-reported outcomes. And as you can see, none of these, although some were widely endorsed, none of these were endorsed in all of the studies. But most importantly, when they reviewed other studies that looked at the signs and symptoms from chronic arthropathy, once again, these are the authors and the years of the paper. This is the source. Now we're talking about signs and symptoms for chronic arthropathy, so from health professionals or imaging. And the symptoms, same one, swelling, reduced range of motion, pain, warmth, stiffness, and really reduced range of motion, fixed flexion. You can see that the signs and symptoms are the same. And this is the schema from that paper that they came up with. In red are the signs and symptoms associated with acute joint bleeding. In yellow, what's associated with chronic arthropathy. And there were some suggestions that you could differentiate with some of the symptoms. So for example, for hemarthrosis, redness or muscle spasm, a tingling sensation, inability to weight bear, a prodromal sensation, tense sensation, or fullness were more likely to be associated with bleeding. Similarly, arthropathy had its own signs and symptoms, but you can see the most common reported symptoms are common to both. And with this in mind, they concluded that overall there is no consensus on the symptoms indicating hemarthrosis. This prompted the team, that same team, to go on and do their own study, a qualitative study that they published in 2016. And this was a consensus study of focus groups, 6 focus groups, 3 of persons with hemophilia and 3 of healthcare professionals. And they sat there in their focus groups and tried to come to consensus as what are the best signs and symptoms to differentiate bleeding from chronic joint damage. And in their consensus process, these were the top 5 ways of differentiating, numbered 1 through 5. So the item would be the course of the bleeding, or the course of the symptoms, the cause, the background history of joint pain, the types of pain, and whether or not there was limitation or the characteristic of the limitation of the range of motion. So coming up with a schema similar, Karen, to the one that you were suggesting. And they tried to suggest that there might be a difference between them. However, as we've already discussed this afternoon, this may not be enough. So this is the study from San Diego that compared point-of-care ultrasound to physicians' and patients' assessment of whether bleeding had occurred or not. And this is the figure from that table that we had heard about briefly before. This is the patient perception for pain, for whether they said there was bleeding or whether they said there was not bleeding, and this is the same thing for physicians. In the dark gray bars when they got it right compared to point-of-care ultrasound, and the white is when they got it wrong. And you can see that only about 30% of time, whether they say there is bleeding or isn't bleeding, do patients get it right. Physicians, not really any better with the physician assessment. Now you might argue, well, that's because it was point-of-care ultrasound. Maybe the ultrasonographers weren't all that good. This is the most recent study. This has just come out. This is from Uruguay, comparing to radiographer performed ultrasound, suggesting not much better. At least 20% of patient-reported bleeding is overcalled, likely more. So when we're thinking about patient-reported outcomes, where does that lead us? What are the bleeding diaries and bleeding apps that we have? What's the importance of those things? And I would have to say the reason I don't like thinking about this is that in all of our studies we rely on this report, and yet we can see that they're likely to be wrong as often or more often than they're likely to be right. My suggestion would be, let's think about patient-centered outcomes. Clearly bleeding is important. And I'm sure if you're a person with hemophilia, whether or not you're having bleeding is important, but perhaps that's because of the functional consequences, the need for deciding about treatment or not, and not the bleeding per se itself. I think we should ask patients about what's important to them, pain, functional limitation, quality of life, social and role performance, and leave the assessment of bleeding to more accurate measures like imaging, and if it's really important, well, let me just give you a story. I'm a rheumatologist, and as a rheumatologist, in years gone by, I've often been referred patients for assessment of their chronic arthropathy or chronic synovitis who are not bleeding. And many times, I would decide the appropriate thing to do was to put a needle in and inject corticosteroids. But whenever I did that, I always aspirated first. And in every single case, I aspirated blood. Meaning all these patients that were being sent for chronic arthropathy, the pain was really probably, at least in part, coming from bleeding. I think if we really need to know, we've got to do some kind of gold standard examination if we really need to know about bleeding, and save the patient-reported outcome measures for things that are patient-centered and matter more to patients. That's a personal opinion, but that's based on the data, I'm going to stand by it. Anyways, thank you very much.